Today, I'm excited to be joined by Dr. Nancy Bill, a leading expert in focal hand dystonia and neuroplasticity. We'll dive into her insights, highlight some of the latest research, and share practical takeaways you can use in your own practice right away. Welcome to Neuro Navigators, a MedBridge podcast where we conquer challenging topics in neurologic and geriatric rehabilitation. Our aim is to deliver actionable takeaways for physical and occupational therapy providers like you through captivating discussions with influential practitioners in our field. To receive continuing education credit for this episode and access bonus resources, make sure to check out medbridge.com. Hello, I'm your host, JJ Mowder-Tinney, a physical therapist with over 30 years of experience working with people with neurologic deficits, as well as the aging adult population. I have multiple certifications, including being a board-certified clinical specialist in neurologic physical therapy and a certified exercise expert for aging adults. Welcome, Nancy. I'm so excited. This is not an area of my expertise by any way, shape, or form, so I'm so excited to learn from you. And I was hoping you could start us off by telling us a little bit about yourself and how you first got involved with focal dystonia.
Well, thanks for the question, JJ. I've been a physical therapist for 63 years, which is hard to imagine. And I've continued to see patients all during that time, even though I went on to get my advanced degree.
Wow.
But while I was at UCSF, and I happened to be chair of the Department of Physical Therapy and Rehab Science, and we were caught up in, moving our program forward from a bachelor's degree to ultimately this DPT. They were looking to start a new program in the health sciences called the Health Program for Performing Arts. And they contacted me and asked if there was a therapist on the faculty who would be willing to serve as a consultant, and no one was interested. So I volunteered because I happen to play the piano, I'm interested in music, and I thought it might be fun because it was an interdisciplinary team: psychiatrist, neurologist, orthopedist, occupational medicine representative, and psychiatry.
Wow.
And we
That's
all
a big
were,
team.
yes, it was a great team and great people. It was really fun for me to be part of this team. And we all understood there's a lot of repetition that goes into music and musical performance. And so you see a lot of people with inflammatory problems from high levels of repetition. But there was one group of people that we just didn't seem to know how to treat, and that was the people who developed a musician's dystonia, which is a type of focal hand dystonia. And at that time, it was thought that that movement disorder was indeed psychological, that there were no findings, neurological impairments that could be identified, and therefore these folks were just having difficulty with a lot of stress and emotional unrest, and developed these funny movement disorders. And so I was fascinated with it also because I didn't know how to treat it. And I decided that I would change my research orientation. At that time, I was doing wound healing. And I went up and introduced myself to the people in neuroscience and talked to a Dr. Mike Merznick, who I kind of call the father of neuroplasticity.
Yes.
And I said, Mike, I've got this problem. I'm happy to show you some videos of people who have a very unusual movement disorder, and we just simply don't know how to treat it because we don't understand the etiology. And Mike was a very strong researcher and using primates as his research targets. And I showed him these videos and he became fascinated. And so we started the project on looking at the origin of focal dystonia by using a primate model. I was not a big animal researcher at that time, even though I was in the animal research area for wound healing. But I have to tell you that primates are a lot like human primates. And it was quite interesting to develop a behavioral scenario that I could create a movement dysfunction that we called dystonia in some of the primates who were particularly anal and perseverative in their behavior, and they would do this reaching task for food. And some of them would do it really, really fast, and we were kind of fascinated with how long they'd work at that task. And others would do it slowly, kind of know that I would have to feed them if they didn't do enough repetitions, and they did not develop the movement dysfunction. But after they developed this movement dysfunction, we did map their brains, and we were focused on the somatosensory cortex. Even though this was it looked like a motor control problem and a motor dysfunction, that what was driving the unusual movements was really the remapping of the brain that occurred in the sensory part of the cortex. So sensory drives motor, and sometimes we forget about that. And we went to the Society of Neuroscience, and I was put on a panel with some very well-known people with dystonia that research dystonia. And we presented our research, and afterwards, people were so fascinated. The newspaper journalist came and said, "Can we do an interview?" And I was really upset because the person from NIH, he was asked the question, what is his area of research that's going to be next? And he said, "I'm going to prove Nancy Bill is wrong." And I was really insulted and hurt, but I should have been flattered that we had created kind of a paradigm shift and trying to understand focal hand dystonia as a remapping, an abnormal remapping of the brain that created this movement dysfunction, and that it potentially originated from sensory dysfunction, not motor.
I'm getting chills only because I just think this whole sensory piece that's so important, and tying that all together and how directly that relates to the movement. And so you were amazing trailblazer back then to start off with that. And Dr. Merznick, holy crow, you worked with him. That's very exciting.
Yes.
And you started in wound care. So there's just so many things in what you just said that I was like, okay, wow, this is going to be a great talk. So that is incredibly exciting. And obviously, he didn't prove you wrong, right?
No, he only proved me that what our initial findings were correct, which is even better.
Yeah, that's really exciting. What a great story. Wow, I appreciate
and
that.
And he doesn't remember saying that. He does not remember because I worked
deniability.
Yes, because I worked with him on a variety of committees with NIH and other groups, and we became, I think, pretty good friends in the research arena. And he said he just can't remember that he said that.
Well, and sometimes that's a good driver, right? When people tell us no.
Yes.
Yeah, right. But that's amazing research. Okay, so that's fascinating. So when you think about the clinician, I mean, the amount of experience you have is massive, and that's so exciting. Why do you think it's important for the clinicians to understand focal dystonia, and for those, and maybe start backwards. Maybe I should start first with, how could you describe it in the context of other movement disorders for those of us who aren't specialized in that area?
So it turns out, if you're interested in really motor control, the most common movement disorder is a tremor. Now, I did not know that till I actually tried to look up to answer that question about why would a clinician even care about learning about focal dystonia. And it turns out that even compared to spasticity and chorea and all other movement disorders, dystonia is the third most common movement disorder. That's sort of all dystonias, genetic originated dystonias, and these focal dystonias. So then I just recently found a systematic review that looked at focal type dystonias that were uniquely either task specific or anatomically specific. And it turns out that since 2010 to 2022, that incidence is 30.8 out of 100,000, which is about 3.1 per thousand would have one of these focal dystonias. And why that's even more interesting is if you look at 1985 to 2010, that prevalence was only 1.6 per thousand.
Wow.
So we've doubled the incidence, which is probably because we've become better at the diagnosis. So dystonia is hard to identify by many people, including physicians, because it's an involuntary movement dysfunction where you get abnormal movements, particularly into flexion and sometimes into extension, that occur at end range. They can be really fast, that occur quickly. They can be really slow. they often are triggered by a sensory contact. So with a musician, as soon as they put their hand on the instrument, some fingers will flex and some fingers will extend, and they can't control that. That it's involuntary. And if you look at an EMG of dystonia and you put a needle in a muscle you think is dystonic, what you see is a very quick activation of the neurons, and the muscle, contracts quickly. And then the patient has a very hard time turning that contraction off. So you can take from a clinical observation to a quick needle investigation and just see how amazing it is that when the needle goes in, that muscle contracts much more quickly than it does in a normal person. And then when they're asked to quiet it down, they have a very hard time. It takes them a longer period to quiet it down. So it is unusual, but it doesn't meet any of the other. There's not a hyperactive stretch reflex for spasticity. There's not, other parts of the body that are moving abnormally in a focal dystonia. It's usually one part of the body or only at one particular task. And then the people who have this movement dysfunction have tried many ways to control the abnormal movement by putting tape on their fingers, for example, by wearing a glove, by getting a different instrument, by putting some kind of sensory material on the instrument to change that interface between the fingers and the instrument. So it is definitely excessive excitation and inadequate inhibition. That's that imbalance for a focal dystonia. And we are, as PTs and OTs, we are particularly likely to get someone referred with a focal hand dystonia, but the most common focal dystonia is a cervical dystonia. So
Oh,
that's a dystonia of the neck. And the second most common is a hand dystonia. And then there's, of course, the blepharospasm, which is your eyelids. You can't keep them open. And I do see people
oh,
on TV who can't keep their eyelids open. And I wondered if anyone had talked to them about blepharospasm. And it can also be a dysphonia or dystonia of the larynx. And these people, are people who are giving lots of lectures or doing a lot of public speaking. And then suddenly, their voice doesn't work anymore and they can't continue in their profession. So it is quite disabling. And they will either be labeled as a hand dystonia, a leg dystonia, a larynx dystonia, or even an umbilicus dystonia, and a dancer who does hula dancing and other kinds of dancing where you see a
like
lot of umbilical movement. And then it's also by task. So the most common is a task-specific hand dystonia called musician's dystonia, or data entry dystonia, keyboarders dystonia, runner's dystonia, and golfer's yip. That's probably the popular one where people put their hand on the golf club and now they can't program and do a nice smooth swing. And there have been several TV shows on golfer's yip, and it follows the same criteria as what we'll kind of develop in our talk today. It's just another type of focal dystonia. It just happens to be popular in people who are famous and suddenly they can't golf anymore, or pianists who suddenly can't play anymore. So those kinds of people get special attention. And even though it's only, quote, 3 people per 1,000, when that person comes into your practice, it is quite challenging. And most therapists haven't had a lot of experience working with patients with a focal dystonia. And many neurologists are not familiar with it either. So you best to have people see a movement disorder specialist in neurology because they have the current data on diagnosing and treatment.
well, thank you so much, because I did not know all of that. And I wasn't thinking so broad. I mean, I knew musicians' dystonia, but that description is extremely helpful. And to think about the impact it has on their life, because it's the thing that they love or the thing that they do, that's everything to them. So that has to be even more stressful. and such a huge impact. I was actually thinking 3 out of 1,000 seems like a lot to me. That seems really high. So I appreciate that. That's really helpful to be able to break that down. And, thinking about the eyelid one, I was just thinking, is that during a movement? Just because recently I was consulting on a person and I was wondering why he was keeping his eyes closed and he didn't know why. Now you're making me think back.
Yeah. So often when you see a focal dystonia that might start as a hand dystonia or, might start as a runner's dystonia or somebody complaining about, they have ankle pain or something like that. If you really look carefully, you'll find that there are some other signs of movement dysfunction that have not really been specifically diagnosed and identified. Like you might see a twitch. Somebody might have a little twitch in their face, their nose, their eyes, or you may see somebody who has blepharospasm, and particularly common in people who work outside in the sun, where you have to kind of squint a lot. So again, that even though there are some genetically related focal dystonias, they're usually coming from, interestingly enough, people who are very much perfectionists, type A personalities, tend to be perseverative. They really got to get it right, and they're going to keep doing it till they get it right. And those characteristics seem to be common across all the focal dystonias that I see. I've never seen a patient with dystonia in my years that is lazy, that isn't interested in being more precise and having a characteristic of being a perfectionist, and there's not a type A personality. Those characteristics, even when I telehealth with people all over the world with focal dystonia, those are very common characteristics. And when they did a study recently comparing musicians and their perfectionism with physicians who tend to be, particularly surgeons who are perfectionists, turns out musicians are more perfectionist oriented than even physicians. And they did this with students. So I guess when they go out and practice, I have seen several physicians, particularly surgeons, that have developed these hand dystonias. So the characteristics are there, and you got to ask about them. And when I asked that as one of the first questions, they kind of laughed and said, "How did you know?"
I bet.
But that's important to know for treatment, because you've got it that these people are under a lot of stress. I've never seen kind of easy-go-lucky person who's an optimist and, life is good. Those are not the people that are getting these focal dystonias. So you really have to ask that question about some personality characteristics and what kind of stress they're under and how long they've been under that kind of stress. And even though we are focused on the movement dysfunction, it's a whole person you're treating, and that has to be part of our evaluation and our intervention.
Well, I would think exactly. I mean, that emphasis is so important because it is going to drive your intervention, how you're going to approach the patient and how you're going to make some adjustments to get the best outcome and how you're going to incorporate some motor learning strategies, right? Understanding them better. But that's fascinating. So all that research, because you are definitely the leader in the forefront in this. And that sounds like a fascinating discovery, that link that you made. What other things did you find that kind of shifted your thinking or, that you can add on to that?
I was surprised because I really wasn't a neuroscientist. I had never done brain mapping. And in the first map, you actually map 24 hours a day for 5 days in a row. So you need a team that rotates in and out. And the team that I had working with me were all experienced, maybe postdocs, but had done a lot of cortical mapping. And I was the person new to the cortical map. And when we produced this map, Dr. Merznick looked at it and he said, "You guys you're totally wrong. That can't be right. I've never seen a map that disorganized." And I said, "Well, Mike, the only thing I can think of is you need to come into the operating room with us and you need to do some of the mapping." And what is fascinating is the maps are so unusual and abnormal, and it's so impressive because the map changes over time, that I was surprised the patient didn't experience or didn't describe having a sensory problem. That they
Really?
didn't notice anything about tactile discrimination. They hadn't thought anything about stereognosis, feeling objects. They hadn't thought anything about, having sensory stimulus delivered to their fingers and they wouldn't be able to interpret it accurately. But I would say 90% of the people I talk to have no idea that they have a sensory problem. And until you do some of those tests, and they can't interpret a letter or number that you wrote on their finger, or they can't decide which is the biggest dowel or which is the most coarse sandpaper. It was just shocking to me and shocking to them, right? Because they thought they were fine. They would never have thought they had a sensory problem. Sharp dull is probably still pretty close to okay, because sharp dull is almost like a reflex. It has different neurons that are sensitive to the painful stimulus. But the cortical sensory tasks of stereognosis and graphesthesia are particularly unusually disordered.
I,
So,
sorry, I agree with you. I would be so shocked only because as a musician, having to move your fingers quickly, I would think they would be better than the average in knowing, you know what I mean? Like in their somatosensory.
well, maybe they are with before they got the dystonia. And
Oh, okay.
one of the theories, I know I didn't say it initially, but I'll bring it up now because it's confusing, is that they seem to have a lack of homeostatic plasticity. And that's a word that you don't hear very much. But what happens is that when you do a task regularly and repetitively and trying to make it better, that your brain changes and becomes better and better. The receptive fields in the sensory cortex become smaller and smaller the better you get at a task. Your discrimination is better. But you reach a place, like I play the piano, I could practice forever and I'd never be a professional pianist. I could never get that good. But I can play and I can enjoy it, but I could never get that good because my brain won't allow me. Even if I really practice hard, it has an endpoint at which I can change it. And what happens in patients who develop this dystonia is that they don't stop. That homeostatic plasticity that says, that you're there, you got it, you can keep it, so on. Theirs keeps changing. And as it changes, then even the location of the maps change their location on the cortex. So for example, the hand map is very near to the face. And what we see in our monkeys who develop these dystonias, that the map, when we put in the electrodes early, we define the map of the hand, and then the monkey develops a dystonia, then what happens is that those electrodes are no longer on the area of the hand. And then we have to move the electrodes and find the hand is mapped on the face. And that's the same thing that has been found with people who have an amputation. Dr. Ramachandran kind of had a paradigm shift when he showed that even though they had removed a hand or they'd removed from the elbow down or whatever, that when you'd go back into the cortex of that patient, you would find that hand that had been removed mapped on the face. So when you would touch the person on the face, they'd say, oh, that feels like my hand. So it's an amazing thing. So
You're blowing up my brain right now just because this is just so incredibly fascinating. And it just, reinforces what we know, how complex the brain is.
Yes.
To think that we can figure it out is just fascinating. But
if that's the abnormality, then in our case, for most of the hand dystonias, the map is altered in location. The receptive fields are usually too big, and sometimes they're too small, but their accuracy is definitely disordered. So you really have to start first dealing with the stress management and the perseveration and the perfectionism. These people need some counseling. They need to learn how to kind of step back a little bit. But you have to start on sensory retraining, and you have to have different ways that you can get people to do the sensory retraining that doesn't depend on someone else. But if you touch yourself, or you draw a letter on your finger, yourself, you already cognitively know you did it. You know what it is. And so people can't really easily test themselves. Somebody has to deliver the stimulus to you in order to start to retrain that sensory map. So getting a family member to help someone, coming in for therapy is not going to be sufficient. And you need to really work with people, get them on the right program. But you can't give enough repetitions and practice and varying that practice and making it progressively harder. You've got to get somebody to find a friend to work with them or a family member. And probably the best thing ever was when I was able to talk to people who live close to each other and mesh them up and
Oh,
have
yeah.
them work together. And they really enjoyed doing that. They both got better and, felt good to know somebody who had the same problem they did. But you do need help. You need somebody who's willing to help you with some of the sensory retraining. Although I have a list of sensory activities people can do on their own. And they can create boards where they can, feel buttons, and they can feel, make dowels of different sizes with different graded sandpaper, and then mix them up and try to put them in order. And also they can play Scrabble. You can feel the letters. Everybody's got to be blindfolded. I try to get people to learn how to read Braille, and they wouldn't learn how to read Braille till I got Braille cards and asked them to bet money on poker. And once they thought they might lose money, and they're perfectionists, they want to do it right, they learn to read the Braille cards. So there's got to be a high level of motivation. You have to kind of keep it fun. And when you have people working together, doing things like playing Scrabble, or, you can buy Braille cards and play a card game, that poker is always good because it's easy to learn, and you don't have, it's all, a limited number of figures that you have to learn to do it. But, you got to make this repetition fun, easy. They got to be right. You don't move on and make things harder, until people get better. So when people say, well, how many repetitions, do I have to do? Carolee Winstein looked at that relative to patients post-stroke, and it can be millions of repetitions. Nobody keeps track, but it doesn't happen overnight. And if you think about the repetitions you see in keyboarders who are on the keyboard all the time, and musicians, and they're all the time, people who sing develop the spasmodic dysphonia. The repetitions are well beyond what they can even count.
Wow. I really love that suggestion of putting people together. Like if you're in a clinic and you're having multiple people who have this diagnosis, and somehow you can find a way to match them up, that sounds like such an amazing idea in regards to, like, you think of peer support and other ways from a motivation. And you talked a lot about different behaviors and where you need to go with some interventions. I know we're going to talk about some more later, but like, what person has the best outcomes from candidates for behavioral retraining? Like what patients do you think are a good fit or not a good fit? Or
Well, I could tell you, first of all, who's not a good fit. The person who won't give up the tasks that caused the dystonia in the first place is a tough patient to work with. The person who doesn't believe that mental imagery really excites the neurons in the area of the brain you're interested in. And the person who thinks they need a medication, that, getting Botox or some kind of scopolamine or some kind of relaxant, to help remodel their brain. Those people who are absolutely dependent on some pharmaceutical intervention are not going to be good behavioral training candidates. So the person who is most likely to succeed is a person who, one, has a good therapist who understands the problem, and two, has a good physician who recognizes behavioral training is a reasonable strategy for intervention. It's not necessarily 100%, because I think we don't know all the ways to retrain the brain to be maximally effective. But it's really tough if you have a patient you've convinced that they have a chance to get better by doing behavioral training, and the physician says, well, you can try it, but it's not very effective.
That's not
that
going to be
that
helpful.
ruins that just
Hmm.
ruins your success. The person who's willing to give up the task during the retraining period is also more likely to get better. And the person who believes that if he changes his position, his relative position with gravity, to really just begin to love their instrument again or love the target, whether it's a keyboard or whatever it is, the person who can change their position and learn to love that instrument again and put their hands on it and not create the dystonia is also a really good candidate. Creative people who come up with other ideas of things that they have tried, who have sensory tricks, those people they're going to be good, compliant patients. They're going to want to get better and willing to try some things. So I was very lucky in the performing arts clinic that I had physicians who believed that psychological support kind of therapy, not saying you're abnormal or you're weird or you're psychopathologic, but you have a lot of stress and you're in a challenging profession, and that they're willing to kind of deal with what are the factors that finally led them, to having this problem. And the other good candidate is the candidate who is still interested in fitness, does some kind of exercise, has a good exercise routine, goes out and runs or goes to the gym. They do believe exercise is important for health and wellness, and they can see that that might be a criteria for beginning to recover from their hand dystonia. So, those characteristics, willing to give up playing, interested in behavioral ideas, can imagine, close their eyes and imagine, going to another environment, or in the case of dystonia, going back in time and having that person imagine when they were on the keyboard doing data entry, when they were on their instrument, playing, when their hand was perfect. It did everything they wanted to do. They had no abnormal movements that they have with this dystonia. And I had one patient who she was about 40. She had to go back to when she was 6, that she remembered playing without any kind of worries. Her hands seemed to know exactly what to do. And of course, she was only 6 and she played beautifully. So she got a lot of, attention for her art. And she had to go back to when she was really young and then kind of come forward and realize what started. When did this movement dysfunction start, and how much stress she was under, how much pressure she got from her parents to perform. And then they would criticize her if she made a mistake. And when somebody come to the house, she'd have to perform in front of those people. And then, her parents just expected her to be perfect, right? And that's a good history to recall, because you've got to get over that in order to prime your nervous system to begin to relearn. So you've got to deal with that, what I call priming the nervous system, which includes a lot of this historical onset.
Geez, Nancy, your experience is just completely overwhelming in regards to how much you know about this. And, thinking about those were key, really great suggestions. I was just thinking, and if as long as you know that, even if you have someone and you get a patient and you're figuring this out, that they have this, but you don't have a lot of experience, that those 4 things were really helpful, because even if there's one that they gravitate to, you could go all in that while you call for backup or find them another person or find a movement disorder referral. I mean, just knowing those, I think, is incredibly helpful. So that's fascinating. And when you think about those, so I have someone come in who has this, or who I'm identifying, I'm seeing this, or they're referred with it. What other kinds of questions do you feel like are top priorities to help guide your treatment? I know you hit some real big heavy hitters, but what else would you add?
I think it's important to ask them to perform their art, whatever that is, or whatever the task is that causes the dystonia. It's really important for you to observe it yourself and to have the patient show you what triggers that abnormal movement. And due to all the things about ethics and privacy and so on, I actually asked them if they would mind if I use their phone to videotape their performance of this dystonic movement. Or I also asked them bring in videotapes of when they first noticed it, because often people are taking videos of themselves when they're performing, or a friend or a family member or whatever. And then I want you to think about the biomechanics of how they use their hand to perform the task, because the intrinsic muscles are incredibly important to the balance of fine coordinated movement of the hands. And many people have really short intrinsics, short lumbricals, or they can't really completely use and isolate their lumbricals because they don't know what they are, as you know, spreading the fingers out, and then this movement of the extension of the interphalangeal joints. Uh, the the third issue is to ask them about their stress. Let them tell you about that. Don't assume that what I said is right. Find out their story. Then I think you need to administer some standard tests. One is you need to look at their posture, which, as most of us know, just the posture manual and the alignment helps you make that without any kind of fancy assessment. But you should test the strength of the intrinsic muscles, and you'll see that they're dominated by the extrinsic flexors and extensors, and people can hardly hold against any resistance for the lumbricals. So it's important to do that. It's important to really give some kind of motor test. One might be box and block. One might be the Purdue. Another might be, a dystonia scale. They have an arm dystonia scale that includes the hand. Another is to really have them fill out a thing on self-awareness and pain. Even though dystonia is supposed to be painless, most of those people have gone through some kind of inflammatory episode that may or may not still be present. So it's important to see what their pain assessment is, not just to assume that it's painless. I also think they should fill out a Berg balance test, because sometimes these people, particularly in leg dystonia, will have a balance problem that's part of the cerebellar system is learning and sensory processing of proprioception. And then I also encourage them to do a depression scale. And you can choose whatever. The Beck depression is easy for them to administer while they're there. And most of these are, easy to administer. Timed up and go, I will do if somebody has a leg or a foot dystonia, again, seeing how much it impairs their ability to be stable and to move quickly. And I just want to reinforce that they have a motor control problem, but their motor learning skills are still normal, which is hard to imagine in the case of this excessive excitation and poor inhibition. But their learning skills have been documented as normal. So as I talk about doing these assessments, you're going to say, oh, well, if they can't do it, they have this motor dysfunction, then why would I be doing these tests? They can do the tests. And they actually do a good job if it's not part of the target task. But it's important for you to see how much that affects the target task. I also use the mirror as part of my assessment. And I know many people use mirror therapy as part of therapy, which I agree with. But if you ask a person to put the unaffected hand in front of the mirror and the affected dystonic hand behind the mirror, and you hand them a pen, just do something really simple. And you hand them a pen and have the same pen for both hands, so they don't look in the mirror and see that the hand in the mirror should look like their affected hand. And then ask them to do something like make a B, or make a D, or make a C, all of those which have directionality. And what you'll see in a patient who has dystonia is when they make a B, they'll make the B the same with the left and the right hand, even though in the mirror, that right affected hand, the B is in the opposite direction. So, it's
Right.
like this. But that's not the way they draw it. They draw it this. Both hands will be the same.
Really?
Yes, it's fascinating.
Yeah.
And they think they're right. So I say to them, check the mirror. Do you see your left hand looks like your right hand in the mirror? Yes, I see that. Okay, I want you to remember that. You're following the mirror. And then they do the same thing again. And so it's hard to
Wow.
really get them to understand they have this reversing characteristic. They also have trouble with right-left confusion. And so some of the NOE things on recognize, RECOGNISE, they have right-left training for the hand. They have it for the arm. They have it for the foot. They also have it for the shoulder, I think now. And you'll find that when they are looking at these pictures, to try to decide if it's right or left, these people are having difficulty with right-left confusion. And that's about the only thing they might say. Yeah, sometimes I get confused about whether that's right or left when I'm looking at an object or I'm looking at a hand. So I also often have them get that program and run the program and tell me what their score is. So
And just to reinforce, can I just reinforce that for a second? Because that's an app. You can get it as an app as well as on computer. Is it on both?
On your phone mostly,
Yeah.
but you can put it on your computer too.
So it's an app on your phone, and I don't know. I can't remember if it costs money. I know I have it.
$8.95.
$8.95. That's nothing, right? Recognize, and it's with RECOGNISE, correct?
Right, and
we'll put it in the show notes because I think that's a great app to have in your back pocket, especially for them to go work on their own, right?
Correct. And Noi.com, NOI.com.
NOI.com. Okay,
that will
so we'll
get
put those
you
in the show notes as well, but I think those are great tips for the therapists. But that's really, really fascinating. Sorry, I didn't mean to interrupt, but I was excited.
The other thing I almost forgot to say is that there is an overlap of the sensory systems. And we did a study where we were looking at auditory discrimination and learning how to improve your ability to hear accurately different sounds, different noises, different intensities, and so on. And so we took these people and before we did the test, we tested them auditorily and found out what their scales were. And then we also did sensory tests. We did graphesthesia and we also did stereognosis. And what was interesting is we trained their auditory discrimination and then we retested sensory. And guess what? The auditory got better and so did sensory. So there's a significant overlap. And sometimes if people get really frustrated with, tactile and things dealing with stereognosis or graphesthesia, I will sometimes go to auditory and make different sounds behind them and, try to get them to discriminate the sounds and do different levels of sounds. I might even put, bells on their shoes, and one shoe will have a loud bell and the other one has a different sounding bell. And that sometimes that was a way to transition to really get them to stick to the somatosensory retraining that they needed to do. Probably the other thing I forgot to say under testing is put people in a funny position and then reintroduce the instrument. So if I had a saxophone player, for example, who had a dystonia, and he was really frustrated because this was his life. He loved it and he didn't want to give it up. So I had him lie down on the plinth, and then I handed him his saxophone and asked him to put his hands on the saxophone. And all of a sudden, it didn't trigger the dystonic movements. And he was so shocked and so amazed. So that one of the beginning trips to use with her, I call it a trick, but one of the beginning tricks to use is change their position. I had a patient with a cervical dystonia that was so terrible, and it caused also a dysphonia. And she came in and she was desperate, very attractive young lady. And I put her on a tilt table, and it was just an inversion unit, really. I tipped her to about 45 degrees and then gently rocked it. I gave her a book and I asked her to read the book as I was rocking her, and her speech was clear and her neck dystonia was quiet. And her parents were standing there and they said, "Oh my gosh, we have just never seen her be like that since this started." So changing their position with gravity alters the pathways of which you process sensory information. So it's really important as one of your evaluation tools is put somebody in an odd position. I might have them lay on their stomach if they're playing a guitar and then put their hand on the guitar resting on a chair. So you kind of have to explore what instrument they're playing in order to really use the gravitational assessment.
So how do you come up with these things? I mean, is it just from you just are just trying a different position? You just decide I'm going to take gravity out and you just make it up as you go, so to speak?
Well,
That's really creative. I'm just thinking of, like, I love that. So you're saying to therapists, if the therapist is like, well, which position should I put them in? You're just saying, take gravity out of play, pick a different type of position, and then give them what it is they do. Correct?
yeah, well, that's kind of it. And I had a therapist who had a dentist with developed a focal hand dystonia. So it was terrible for him to be working in somebody's mouth. As you know, you've got to be really careful. And he happened to have graduated from our program many years ago, and he is his own wonderful therapist today. And he had this dentist and came in to see him in his clinic. And he put a set of false teeth into anatomic pelvis, just the skeleton of the pelvis. And then he told the guy to bring some of his instruments from, working as a dentist, which he did. And then he had the dentist reach in and try to work on these teeth inside the pelvis. And he didn't have the dystonia. So you can see there's just a variety of ways to change not only gravitational, but just the environment in which somebody is activating their dystonia. And one of the treatments that's been kind of interesting is called the slow down method. And that's where you actually find the task and you try to slow the person down to perform the task, whatever that task is, where they can actually perform it normally. And then you ask them to do that for 2 weeks. This is Dr. Sakai from Japan. You ask them to do it for 2 weeks at that slow pace, and then you ask them to increase the speed by maybe 20% and do that for 2 weeks. Again, no dystonia, until finally you can do the task normally at normal speed. And he found that if you started in the trigger position, meaning the position that triggered the dystonia, that's where you start with this slow pace training. His percent of recovery is somewhere between 50 and 75%. And I would guess that most people just don't stay on that task, to often enough or frequently enough to really change the brain significantly. But the good news is that even though you'll read these review articles written by physicians, they minimize the behavioral training to this day. And it is very annoying to me, but they minimize it. And we have really shown that if you do these tasks of retraining this somatosensory system and you remap their brain, which we did with using MRI magnetic training, that we remapped the brain. We mapped it initially, then we remapped it after the training. And sure enough, we normalized their maps to be similar to people who don't have a dystonia. So we do know, we have definite confirmation that we can change the brain with training. And I always start with mental imagery, because if you can just imagine, close your eyes and imagine doing that task. And, they want to do the task. That's why they still do it, even though you ask them not to. That you just say, instead of physically practicing the task, I want you to mentally practice the task. I don't want you to have the instrument near you at that moment. I just want you to mentally practice. And it has been shown, not by our research, but other researchers, that when you mentally image a task, you use about 30% of the neurons that you would use if you were actually doing the task. So you're not recruiting 100%, but you're recruiting 30%. So it's a great way to start.
You are brilliant. So I don't know. I don't even know where to start. I love all of that so much. And I think those suggestions are amazing. I think that the piece about slowing down, I mean, just having more options for people who are thinking, oh, I know what I was going to say. The behavioral part, you said that it really bothers you that they're not acknowledging the importance of, why do you think that is? I mean, it seems so, what's wrong with that? It's just an added intervention component that has been seen to be helpful. And as a whole person, it's helpful. I don't know that I get it.
Well, I think often a physician has never suffered a particular problem, like a dystonia or a spasticity or chronic pain. And I'm not sure that they're really as sensitive to this issue of retraining as they should be. And I will give you an unusual example, and you can eliminate this if you want, but my husband is a surgeon, and he was hunting, and someone did not unload their gun. And the truck took off after they'd finished their hunting day, and the gun went off because it was kind of loaded. It was slanted against the seat. And my husband was the last one in, so he had his hand across the seat, across the other two people, and that gun went off and the bullet went through his hand. And he is an ear surgeon, and you can imagine he didn't even feel it, so there was no pain, really just a loud noise. And then his cousin turned around and said, "Fred, that bullet went through your hand." So Fred was devastated because he thought his future was over as a surgeon, and he was still young. He was in probably late 30s. And I said it had eliminated really the service to the index finger. And on the phone, I said to him, "Just have them amputate your index finger." He said, "I can't possibly be a surgeon and not have my index finger." And I said, "Yes, you can." But anyway, he waited till he had an appointment with a hand surgeon back in our area. And the guy said the same thing I did. So he had his index finger amputated, but the skin of his index finger was used to cover the dorsum of his hand. So the top of his hand felt like his index finger, right? And that it was confusing for him to use his hand when the index finger was such an important part of holding an instrument. Then it was really disorienting to him. So I begged the surgeon to keep unwrapping his hand so I could do sensory retraining, so I could try to retrain that skin so it didn't feel like his index finger. And you won't believe this, but he had surgery on a Monday. On Wednesday, I delivered him to the clinic, and I said to his chief, "Keep him busy. He can supervise the residents in the clinic, just have somebody else go to the operating room." That man was back in the operating room in about 6 weeks because he learned to use the rest of his hand without the index finger, and the sensory information that he was getting from the dorsum of his hand was relatively normalized. So when he put on the surgical gloves and things like that, it wasn't distracting him from functional use of his hand. So I'm just telling you that people have a very hard time with the sensory training. It takes a lot of time. It's not always fun. I tell people only do these kind of sensory activities for 5 to 10 minutes at a time. Do them before dinner, do them after dinner, do them, whenever you're together. Because if you do it over the long term, you both get bored with it, and then it's not going to be effective, right? It's just not going to work. But I think the average physician has not experienced these kinds of training tools. They think it's just, yeah, you can do it, but it's not effective. And when it isn't effective, it's because people are not engaged in doing it. And people ask me, well, how long will it take? And I don't always have the right answer, but right. I do tell them about a violinist, a young man who this was his love, his life, his income. He was married. And I said, you're going to have to give up playing for a while. And these are the things I want you to do. And he did that. And he worked intensively with his wife, who was a nurse. And he was back to playing in a month. That is highly unusual. But he worked so hard. He was so committed. He was such a positive person. He did it with enthusiasm. They played Scrabble. They read Braille. They played games with Braille cards. And he was back to playing. And I've only seen him once since then. I assume he's still fine, because after I saw him maybe 6 months later, he called me and told me he's still doing well. But I think that most people just are not as committed to this kind of training. And so it gets a bad rap, but it's probably just as effective, if not more effective than Botox. Botox will ultimately make muscles weak if you keep repeating it over time. And that's the most common treatment for all the focal dystonias, particularly cervical dystonia and often hand dystonia. But after a while, when people start to get weak with hand dystonia from Botox, they don't want it anymore. Then you've got to work on really trying to see if you can strengthen the muscles that are weak. And that's probably the negative side effect of Botox. And there are others where the Botox effect goes beyond the target in muscles, for example. But it's the most popular treatment. It's what all physicians will tell you. Now we're talking about surgery and doing phlebotomies and, things like that. So I did go to the operating room with this gal who had the cervical dystonia, and it's a pretty amazing process because I was the one to keep her neck quiet while they implanted the electrodes to stop the dystonic movement. And if you didn't have somebody who knew how to stop the dystonia, I think the success in the operating room is more limited. But in a general dystonia, surgical intervention is really common, and I strongly recommend it. But in these focal dystonias, I think you need to do everything you can from a conservative perspective before you move on to, doing something that is definitely has a potential consequence. And I remember this guy was in marketing and he had a cervical dystonia, and it was really getting in the way of his professional success. He saw Dr. Farias, who people might have heard of, who's a kinesiological developmentalist down in Southern California. And he works with patients with dystonia and does movement retraining with them. And he thinks he's pretty effective, which I know some patients who've seen him and have done pretty well. But this one guy did not do very well. And he got more and more frustrated. So he actually turned on the music, loud, hard rock music, and he started dancing to the music. And, people get all kinds of gyrations, as you know, when they dance hard to rock music. And he rocked away his cervical dystonia. So dance, has a positive effect for patients with Parkinson's disease. It can have a positive relationship with people who have a foot dystonia. And it can, in this case, he did a special podcast on how he effectively danced away his cervical dystonia. So keep these options in mind. I mean, it's really, it's what makes therapy great. You can be creative. If you understand the basic mechanisms, you just kind of put it together in different ways and to be successful.
Wow, Nancy. So, we're out of time already, and I feel like we're just getting started. So
I'm
we
sorry.
definitely need to have you back on sometime because I just keep thinking there's so many people who I don't know how they have access to your brain, but it seems like we need your brain replicated in more places and disseminating all of this really great information, because you helped me tremendously just in this talk of giving so many amazing examples and getting us to think outside the box. And I was just thinking also with the whole behavioral question that I asked, really, if you're not familiar with dystonia, you might think the same thing as like, okay, well, they just need to get Botox. But I think for me, you gave me like inspiration of there's so much hope and there's so much other opportunities. And even if you don't have the answer, to my listeners out there, those answers are out there and there's so much potential. And really, I do think we need to have you back on so we can focus. You have so many other intervention ideas, I know, but you gave us a tremendous amount of information in this last hour. And I am in awe of everything that you have done in your career and how much you've been helpful. That was stunning.
Well, I hope that helps people. My goal is to give people the challenge, the creativity, the interest in doing all you can to discover new ways to get people to do better. And I think we are lucky we're in this profession of rehab. And I think, time is going to come. My husband didn't believe in this stuff until he had this problem. He didn't believe in exercise until he got old. And now, he doesn't do all the things I do, but at least he'll ride his bike every day for 35 minutes and get his exercise and talk to people about exercise, even though he's now retired. So I'm telling you, it's a matter of find people you can work with, and particularly a team in neurology who's open to other explorations besides medication.
And you're a woman after my own heart. We need to be creative. We need to keep thinking. We need to have more ideas. And I feel like you probably gave a lot of people hope with this podcast. And I hope that they have the chance to listen to that. But we're out of time. And so I just can't thank you enough, Nancy, for helping us go through all that information and give us so many amazing examples and all your practical wisdom. It was just a great gift that you gave us today.
Thank you very much. You've been great with your questions. I like your enthusiasm too.
So I'm so excited. I hope that the clinicians out there, you take so much from this and get some new, fresh ideas and inspiration. Just can't thank you enough for tuning in, and we'll see you next time.
Bye now.
Thank you for tuning in to this episode of Neuro Navigators by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Neuro Navigators also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or challenge that you'd like to see addressed on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcasts@medbridge.com. As we wrap up today, remember that your dedication makes a difference. We appreciate you being here to navigate these topics and hope you enjoyed our deep dive into everything neuro. See you next time.